So let's talk about equipment. Now I want you to think in your mind, as we're getting started, about your equipment, where it's at. Where's your emergency equipment located? In your mind, where do you see it? Don, where's yours?
Some of it's in the room. A lot of it's in the room.
Good. That's what I wanted to hear. The crash cart is not your emergency medication. That's your crash cart. That's when, oh my God, it's already too late. All right? That's for everybody to use. Oxygen source, the suction, bag valve mask, airway adjuncts, and intravenous access. There's your crash cart. So here we got emergency medications, non-invasive blood pressure unit, pulse oximeter, capnography, electrocardiograph, and then all the medications and airway stuff that's in your crash cart. Oxygen delivery. Oxygen must be available in the room. Oxygen saturation, there is a minimum of 95% on room air or on supplemental oxygen. So 95% is the number you don't want to go below when you're working with them. The SaO2 should be monitored every 5 minutes. That means what? You document it. It's monitored continually, but you document it every 5 minutes. So, okay. So let's look at IV access. IV, what size IV gauges do you use, Vicki? 20? 20, 24. Some places will tell you what size. 20 is optimal, so you can keep fluids going. You don't take the IV out after you do your sedation, by the way. Now, and you don't have to have a running IV. You can have a help lock and do your IV there. For me, I like having the fluids going because if something does happen, one of the things those fluids will do is will help push that medication through the vein system when you turn it up high. So I like having that available. All right, so let's look about the induction phase, which means right before you're getting started, you're getting ready to start giving your sedation, you want to know what the pulse rate is, O2 saturation. Always document your baseline. Run a 6-section strip, just so if something does happen. This is what I had when I started. I've had twice in my lifetime, which means over tens of thousands of cases, I've had 2 that we canceled because of just doing that prescript, because they had weird arrhythmias that nobody had picked up because there was no reason to pick it up. So that happened with that person. Look at the level of consciousness. That's during the induction. And when we're talking about induction, we're really just talking about starting that first sedation phase. What is their level right before you start? And you do that behavior. How do you find out what their level of consciousness is? Talk to them. Talk to them. If they let them slur speech, that means you're doing a good job. Slurred speech is a good indicator of good sedation. Documentation of vital signs every 5 minutes, LOC every 5 minutes. And then oxygen delivery. You got 3 types: nasal cannula, simple face mask, bag valve mask. Now these are the delivery systems. We're not getting into intubations yet. The cannula. The cannula itself. I've gone in and I've seen people, usually it's at 2 liters, which is fine. I've had them turned up to 10. Is that any good? That's a waste of money, because anything over 6 is not going to give you any more than 44% O2. So it goes up 4% for every liter, between 1 to 6 liters. So there you are. What's normal air?
21%.
21%, thank you. So what we're looking at then is 21%, you give them 1 liter of oxygen, you only go up 3%, you go up to 24. If you give them 6 liters of oxygen, you go to 44. Give them 8 liters of oxygen, you go to 44. Give them 10 liters of oxygen, you go to 44. So that's what you need to remember. You're never going to get to 100% with that little nasal cannula. However, if we take and put a simple face mask, we can get up to 60%. Anything over 8 liters is not going to give you more than 60%. 60 is the highest. But you'll see most people with it turned to where? 10%. Let's dry them out. Put it on 10. Now, give them a cigarette. I see it at Walmart all the time. They'll walk around that on, they're smoking. They say it makes it easier to light their cigarette. They get a bigger flame. All right, but let's add this. What are we going to add to the face mask to get 100%?
A reservoir.
A reservoir. Cool. So now we can get them up to 100%. 10 liters, 100%. And if you're having problems, that's where you want to go. Or if you've got somebody that's got the sleep apnea, any of these things, you may want to go there. Most of the time, you do fine with the nasal cannula on 2 liters. They do great. However, we'll talk about that later. Bag valve mask, it's got some problems. What's the number one problem? I don't expect you to know. I made it up myself.
It's hard to, like you said, if you don't do this every day, it's hard to get the right position, the seal.
Coordination.
Yeah.
It's also made out of plastic. And your operating room is like this room. Temperature's up, temperature's down. So every time the temperature changes, what happens to that plastic? Expands, contracts, expands, contracts. Until the next thing you know, you pick it up, and it's not even got the mask on the bag valve. It just falls off. So now, Valerie brought up I think, an important part of what we're doing. If you're doing a lot of sedation, then you need to at least, I would say, once a day, just get the feel of that mask. If your department can afford a mannequin, having a mannequin where you can just go kind of practice once a day. So what you want to do is practice. You'll probably never have to do it, but if you do, then you're going to be good at it. That's the whole. It's not an unnatural feel. It feels comfortable. It feels natural just to go in and if you don't have a dummy, just have one of your dummy workers there. Get your technician and set them down and go through it. Or do it with yourself. See if you can hold it on yourself. See what it feels like. On second thought, don't, because then you got to clean them. So just work with them. Make sure they work. That's the main thing. They are going to fall apart. And sometimes we start here, do a head tilt, and here's what happens. All you're doing is getting that tongue off of the top of that epiglottis so air can get into it. Does that look pretty simple? That's the simplest thing to do. Also, when you do that, guess what else is going to happen? It's going to stimulate them to kind of wake up. And don't just reach up there and go, Charlie, you're going to feel my hand on your chin. I'm going to have you kind of look up here at me. And you'll start breathing better. Or you can do the jaw thrust. You get back here and push forward. Now, if they're in deep sedation, that's a good one. Why is that a good one in deep sedation? Put your hands back here and do it. Yes, it's painful. You grab a hold of that jaw, it hurts. So that's going to wake them up. And then we're looking at a C. This C here, this holds the top of the mask. So this is the top of the mask, holding it down. And these 3 fingers go where? On the jaw. You just can't breathe if you're going to do it that way. If you get here, you're going to push over and can't breathe. So you got to keep it on the bone. So that's what happens. Now, here's the other thing that happens when they lay around in there. They flatten out. So be prepared if you're going to pull it out to be able also to blow it up. So making sure that should be a part of your almost, and it takes a little bit of air to fill that thing up too. But once you got it full, then you can get a seal. Simple and easy. So in your bag valve, your little bag with your bag valve mask in it, make sure you've got at least a 20 cc or 30 cc syringe in there that you can make sure you've got air. That'd be the other thing to put in that program.
Do you have any tips if you have a patient that has like a full beard to get a better seal? Because sometimes on the air.
Yeah, I do have a big tip. Be sure you don't sedate them. Very difficult. You may not be able to get a good seal because, I mean, let's face it. If they've got a full beard, I'm glad you brought that up because that's an indicator of having a problem if you got to breathe for them. That might be one where you have to end up putting in which you don't want to do it, but at least it's better than trying to intubate them. But they could gag on you too, so. Vigilance and being very careful. Then the other is the E. That's these 3 that you put down on the chin. or you can get some help. There's one person actually just holding the mask. And if you're going to do somebody with a little bit of a beard, you're going to have to do this. Now, you could get you some of that caulking compound and just put a little stream of that on there before you start. He won't like you when he tries to get out of his beard, though.
Yeah, one of our nurses used to be a flight nurse, and he said they would put Vaseline in the beard.
That would help. Then why are you asking me? Why don't you tell me?
Because
Which you just did.
That was like a really bad no-no. Or
Well, Vaseline's not going to hurt anybody. And what it will do is create a substance between each of the beards. So yeah, I never thought about that, never heard about it. So that would be a good idea. So you hear that, everybody? Use Vaseline. So 2 hands, there's 2 ways of doing it. Now here's 1 hand plus doing it. So you're doing both yourself. Now, take your hand and put it in this position, everybody. And they've got to be pulled tight because you've got to put pressure. So it's like making a muscle. How long does it take before it starts burning and hurting? Don't take long, does it? So you can imagine you're not going to be able to do that very long because it's going to hurt. They're not used to that position. So that's the key. And then here you're looking at that and then breathing the other side. So what are airway adjuncts? Any questions about the mask and stuff? Because now we're going to look at other adjuncts. We're going to talk about nasal airway, oral airway, anesthesia, endotracheal tubes, laryngeal mask. All of these things that are there and should be in the room, not outside the room. In actuality, they ought to be the nasal airway and the oral airway ought to be on whatever kind of a cart you've got your medications and stuff. So if you need it, you reach and get it. And a tongue blade with it, make it a lot easier to utilize if you got a tongue blade for the oral airway. So those are one of the things to be thinking about. So let's talk about these adjuncts. The nasal airway. Placed in the nasopharynx and inserted past the obstruction, tongue, and soft tissues to maintain the airway. So what do they look like? Simple, right? Now, how are they made to be used? Do they go right, left to right? Which scenario do you put it in? What are they designed for?
to just get you an open airway, and suction through them, and there's no left and right. It depends on which way you turn your bevel.
Well, I like the way you explain it because you're half right and half wrong.
Okay.
They have a new airway out that is neutral. It's come out in the last year or 2. But the ones that we're looking at up here are designed to go into the right nair, the right side. Why? Because it has that bevel. Mm-hmm. So if I put it in the left side, what's that bevel going to be up against? The throat. Because you're going to go past the septum. It's going to be in the throat. So it can get, they try to breathe in and it sucks into that side. All right? Now, however, can it always go in the right nair? No, it can't. Not always. So what you want to be looking at then is how do you know which nair to put? You know you want to go to the right because that's what it's made. Unless it's one of the new ones where the bevel is actually in the middle, not right or left, neutral. So if you put it in, it's going to be towards the throat, the opening. So now, how do you know which one to put it in? You know it's supposed to go on the right, but how do you know it will? What if it won't go on the right side? And why would it not go on the right side? Deviated naval septum. So how do you determine whether or not, if you have to use it, and you should do this with every patient, by the way, if you've got to use it, how do you know you're going to be putting it in the right spot? In the right nair or the left nair? Oh, gross. Look at their nose. Huh? Well, you can do this. Either you can put your finger up here and say blow, which I don't recommend. I've got caught with that one before. But have them say, you're going to demonstrate. I want you to do what I do. Put your finger on you take your left hand and put it here like this and go. Then take your right hand and put it here and go. So the point is if that right one's, if you do this, the right one's clear, you don't need to worry about the left one. but the right ones don't blow. Now you got to find, what about the left one? Am I going to have a, which means then you may have to look at a smaller airway instead of a larger, the size you might want to use. So it's just that simple little technique. Say, hey, let me see, blow through your nose. Now, if they got a really bad cold, they shouldn't be there anyway, so there shouldn't be a lot of snot running around, so it should be okay. All right, so here's what it looks like. Now, this is the other thing. Which way does thin air go, does it look? Looks like it goes up that way, don't it? Well, if you try to put it up that way, and you get clear fluid back, just take a little taste of it, and if it's sweet, you know you went in the wrong spot. Because you can do that. All right? It actually goes straight back. Now you got to go this way just enough to get it started, and then you bend it back this way, and it goes straight, and it's already curved, so it'll slide right into place, and it's got to be long enough to go into the right ear. So there's what it looks like. There's what it looks like with the, why you had to do it, because the tongue's falling back on it, but at least you still got an airway. So let's take a video and see how we do this. Now, when I went to anesthesia school, one of the things we had to do is put in our own nasal airway. They didn't have those nice little soft ones like they have today back in the 70s.
Once again, this is 2010 EMT class, nasopharyngeal airway. We're going to look up his nostrils. The right one is usually bigger because that's the one he picks all the time. All right, so go ahead, the bevel towards the septum. You show him how you measure it.
From the nose to the, what did you call that?
Tragus of the ear.
Tragus of the ear.
Okay, good. So go ahead and stick her in there.
And swallow.
Okay, so stick it in there just a little bit, then bring it up. There you
Like
go.
this?
Yep. I have to put one more lube on there.
Swallow.
Keep pushing. Keep pushing. Faster you go, the better it is.
Did you hear that?
There we go. Go ahead and pull it out.
That's the same one that was in her nose. Yeah.
All right, any questions about doing that? He started up this way, and he said what? Pull it up, pushed it back, and then they remembered they need to put some lubrifax on it, and then they moved it down the ear. Put lots of that. My recommendation would be to use lidocaine gel. That way, if it does have to stand for a while, you got the lubrication so it doesn't make it raw, but it also numbs it a little bit so it's not uncomfortable. You don't have to, don't put too much. Put too much and they're laying there and it starts dripping back, and what's it going to fall on? Vocal cords. Now they're paralyzed. All right. And then here's what our oral airways look like. They come in a lot of different. Now this one's got the hole in the middle. Most of them come looking like this. They've got the side, so it doesn't matter what you've got. The key here again is making sure that you know what length, because if you don't have the right length, what's it going to do? It's going to go right up against the tongue and going to block you out. So let's look at how they've done this one. Now, is that correct? He's measuring it to make sure he's got the right size. Is that correct measurement from what you learned from the nasal airway? You measure the same way?
No, it needs to be flipped, doesn't it?
Yep, like this. So you go from the trachea of the ear, I call it the earlobe, round to the lips. So if that's long enough to reach those two areas, then it's long enough to get past the tongue in order for breathing. Now here's a guy getting ready to put one in. He's got tongue blades, which I agree with. But he's also got the patient's eyes covered because he's going to be working over the face so he doesn't accidentally scrape something. And he's got a rubber tube hanging from his mouth there. That's not for feeding. That actually hooks to a thing called a precordial stethoscope. So he'll put that on the patient afterwards. And then he's opening up and puts that tube right in. The other thing you can do is take a 4x4, grab the tongue and pull it out would be another way to put it in. And then we'll talk about a couple of others. So there's the simplicity of it. Move it. All you're doing is getting that tongue out of the way so you can move that oral airway back to the back. Now, who do you not put an oral airway in? A patient that's pretty well awake, because it's going to gag them. You know, stick your finger down your throat, and if you gag, that's the thing with sticking a big finger down this guy's throat. Now, there are people who do this. How many put them in by putting them in upside down and then corkscrewing them in? I am not a proponent of that because you can really rough up the soft palate and then they're sore for days after and they wonder why. You can also make them bleed. So I'm not a proponent of that one. Here's what you don't want. I've had that happen before. You're wondering, I don't care how hard you push, you're not going to get anything in with that bag valve mask. So you've got to make sure you got the right length and you pull the tongue forward with a tongue blade or something to make it work. And then, of course, there's the endotracheal tube. That's for absolute control of the airway, but also controls something else. Not only does it control the airway, but it gives you a safety net against aspiration because it's got that tube to protect the airway. Not 100%, but it's a lot more than not. It's in the high 80%. Size, again, is having the right size for the person. And here's what an endotracheal tube looks like with the cuff up. You put it in, you put it up. We'll see a video of that here in a minute. This is a non-cuffed one. About the only place I've ever seen many non-cuffs is in pediatrics because you can create bariatric trauma if you don't have a way for that air to get back out. So you take a little kid, it don't take much. So you need it's like an escape valve when you put these type in. That's what they look like just past the vocal cords. Don't go any further than that. So let's look at how this works.
Ensure that the equipment is prepared and check that the laryngoscope is working and the cuff on the tube inflates and deflates properly. Pre-oxygenate the patient with bag and mask ventilation for up to 1 minute before attempting to intubate. Standing behind the patient with the head in the sniffing the morning air position, with the left hand, insert the curved blade of the laryngoscope into the mouth over the right side of the tongue, displacing it to the left and upwards. Advance the laryngoscope slightly until the tip of the epiglottis can be seen posterior to the back of the tongue. Advance the tip of the laryngoscope blade into the vallecula between the epiglottis and the tongue. With the handle of the laryngoscope pointing away from you at 45 degrees, lift upwards and away to lift up the tongue and epiglottis to display the vocal cords and the laryngeal opening. With the right hand, insert the endotracheal tube from the right-hand side of the mouth directly between the cords and into the trachea until the cuff passes through the cords. The markings on the tube at the incisors will show between 21 and 24 centimeters in the average-sized adult when the tube is in position. Remove the laryngoscope and inflate the cuff with approximately 15 mL of air to prevent air leaking during ventilation. Attach the tube to the bag and valve apparatus and ventilate the patient with the oxygen flow on 12 to 15 litres per minute. Confirm the position of the tube by auscultating over the apices of the lungs, the axillae and the stomach. If it is not in the correct position, deflate the cuff and remove the tube. Resort back to bag and mask ventilation and repeat the intubation process from the beginning. If the tube is in too far, the right lung will be ventilated only via the right main bronchus. If this occurs, deflate the cuff and withdraw the tube 2 to 3 centimeters. Re-inflate the cuff and recheck the position. When the tube is in the correct position, tie it in place with cotton tape and attach the tube to the ventilating apparatus and ventilate the patient.
Questions about that? Pretty straightforward, huh? As long as you got a good melon potted one, it's straightforward. How many's ever put in a laryngeal mask airway? Okay, they're kind of unique. Take a lot of air. We'll watch this video and we might be pretty close then to getting to the what I would call lunch after we watch this video.
What we're about to demonstrate is the correct insertion technique for the intersurgical solus laryngeal mask airway. Firstly, it is important that you select the correct size for each patient and the patient weight does appear on the airway tube. Next, prepare the laryngeal mask airway by fully deflating it to a very tight vacuum. Contrary to some popular belief that there should be some air in the cuff, This is not so because a filled cuff can collide with the epiglottis. Next, prepare the solus for insertion by putting some gel or lubricant on the back of the cuff. Just on the tip of the backplate is all that is required. Then, in readiness for the correct insertion technique, insert your index finger into the slot formed behind the flattened cuff and the junction with the airway tube. Then prepare the patient by tilting the head back and bring the tip of the laryngeal mask airway laterally towards the patient, not downwards, but resting the tip behind the teeth and gums, because you're going to utilize first the hard and then the soft palate of the patient to perform a sweeping action that optimizes the anatomy as an introducer tool. Inserting the laryngeal mask vertically or obliquely brings about difficulties, but by following the curve created by the palate, rather than bouncing off the back of the throat, is by far the simplest method of effective insertion. So we are ready now to start inserting the laryngeal mask airway. And there you see it, following the natural curvature, with the finger going as far as it can, and then using the other hand to stabilize the laryngeal mask as you remove the introducing finger. Then with a pre-prepared syringe, inflate the correct volume. You will notice that not only is the cuff inflating in the pharyngeal cavity, but the connector is also rising slightly, which is an indicator that the laryngeal mask has been fully inserted. The tip of the cuff is now sitting over the esophagus, which is acting as a form of partial stopper, either against reflux coming up or possible minor leakage of gases into the stomach. The epiglottis is resting over the top of the cuff, and the whole of that section is now completely filling the pharynx, which is a special feature of the laryngeal mask airway, because now the nitrous oxide or other gases are being directed solely through the trachea and into the lungs.